Pause there. For the Pediatric Super-Glottic station, we're going to gather our equipment. So have a variety of sizes of eye gels and make sure that you use your length-based tape or any color-based system to get the right size device for the patient. You may need a tongue depressor to help move the tongue and some padding to help position the head for the patient. And then have your confirmation with your CO2 and an SpO2 probe as well. And of course, your BVM with standard PEEP and pop-off valve. So we'll start by choosing the appropriate size device. One thing that I want to bring your attention to for the pediatric devices is the smallest size pediatric eye gel does not have a gastric tube port. Anything above a size 1 will have a gastric tube channel. And then don't forget to lubricate the back of the device before you insert it. So position the airway, and in a really small mouth, instead of a tongue jaw lift, you may have to use a tongue depressor to lift the tongue out of the way. And again, slide the device midline all the way down until you get it seated. Now, I'm keeping some downward pressure while we're attaching the BVM, and we're gonna squeeze the bag just until chest rise. If I don't have good chest rise, just like I do in an adult, I may need to reposition the device up and back down until it's seated until I get good chest rise. Once I have good chest rise, now I'm going to confirm with my CO2. Remember, the smaller the patient is, you may not get a good waveform on your capnography. So chest rise is good confirmation. Listen over the lungs and the epigastrium, but ideally you also get an end tidal reading. Make sure you're using an end tidal device that's appropriate for the size of the child. Lastly, make sure you have a good SpO2 reading. Again, if your SpO2 is low, we can gradually titrate up our PEEP to improve oxygenation.